Good evening, dear colleagues, my seniors and my junior colleagues, dear students. I welcome you all to this today's session on WebEx platform organized by RESA DNB Online Academic Activities. Today with us we have Professor Dr. Sudheesh from Bangalore Medical College. He is the Professor HOD Department of Anesthesia, Bangalore Medical College. And he has been the immediate past editor of IJA International Journal for past 10 years, and he is editor and is ethical committee member for he's heading the ethical committee for two medical colleges, Bangalore Medical College and ASA Medical College, Bangalore, and he is also actively involved in teaching research methodology and statistics for all ISA related activities all over the country. He has conducted several workshops also on that, and he has been actively involved in several research and publications in international and national journals. So I heartily welcome Dr. Sudheesh.
Good evening, sir.
Today,
Good evening, Kam.
yeah, good evening, sir. Good evening. Today, I have requested Dr. Sudheesh to share his vast experience in research methodology and statistics, the basics relevant for postgraduate academic research activities and thesis. Over to Dr. Sudheesh. Thank you.
Sir, good evening, sir. Kamashi, sir. It's been a great privilege to be on this platform with you, and I'm really thankful for you for considering me for this job and giving me this task to help the PGs with regards to research and publications. So as I know, but since the most of the target audience is postgraduates, I'll be touching upon very basic aspects of research methodology, which involves even including writing a synopsis, like as to what should be there and what not to be there in the synopsis. So once you understand the process of research methodology, then automatically writing a synopsis is not a big difficulty. But of course, I'll be touching upon the important things when we present, as I present the topic. So one thing I need to tell is if many times what happens is whenever we talk about research methodology, most of the times the first thing what we think about is the statistics and calculation of data, calculation of statistics, doing so many statistical tests and applying statistical tools. But at this point, I would like to emphasize that research methodology is not statistics, and statistics is just 10 or 20% of the entire research process. So whenever you plan for a research work, statistics forms only around 20% of the work, but rest of the 80% is about the scientific content of the research, and therefore you need not bother so much about the statistics. And second thing, of course, we should have some basic knowledge about elementary knowledge about the statistics, but we are not here to become a statistician. See, whenever you drive a car, it means that it's not necessary that you should know the entire mechanics of the car. It's just that you should know like where the car's basic things are, where it is, what are the basic things you need to check. For example, oil sump, where is oil sump, where is gear fluid, where is brake fluid. Those are the things what you need to know. You need not repair that. You just need to know just for the sake of checking and monitoring whether they are in appropriate amounts or not. Likewise, even in research, statistics is just for you to have a knowledge about what test to, whether the statistician has done a right job or not, just to cross verify. Or in case if you're finding something extra which you need to understand, maybe in order to put it across in a much more statistical language, what they understand. For that purpose, you should have some statistical knowledge. Otherwise, research methodology actually it is something more than just basic statistics. So that's what I'm going to talk in the today's inaugural talk of this particular webinar. Without wasting much of your time, I would like to start off with the presentation. Sir, can I share my screen, sir?
Yes, please, sir. Yes, please.
Okay, thank you, sir. I think my screen is visible.
Yeah, it's sorted.
Yes, sir.
We are able to visualize.
Nice. To start with, The most basic fundamental thing what we need to know whenever we start a research is what kind of a research we are going to do. So whenever we talk about research, most of the time we think about just some comparative studies where you try to compare drug A with drug B or technique A with technique B or instrument A versus instrument B. So research is not only about that, but research is something beyond that. For example, you might just observe what's going on with a particular method of anesthesia or with a particular technique or with a particular method of management of a patient or a set of patients with a particular fixed kind of a comorbidity coming in a series, and you observe what goes on in them and report that. Even that forms a research only. So therefore, research is not just about intervention, but also silently observing what's going on with the patient, documenting and collecting data and reporting it in a nutshell manner. So therefore, when we when you talk about research, we do come across various types of research. So we'll just have a quick overview of research for the next 10-15 minutes or so. So earlier, the entire medical or clinical practice was based on an expert opinion or authoritarian judgment. Most of the time we used to tell that he's our professor, so whatever he says is right, or he's an authority on that particular subject, so therefore whatever he says is right. And how did he get that authority? Just by doing so many cases in that particular area. So that's how we were just thinking in those days. However, those judgment or expert opinions didn't have any reliable evidence behind many accepted healthcare interventions in earlier days. So in 1971, Archibald Cochrane wrote a book in which he did advocate the use of randomized control trials to make medicine more efficient and effective. And he is rightly named as the father of evidence-based medicine. Subsequently, in 1981, David Sackett et al. Initially called it as a critical appraisal of medical literature. They termed this coin of critical appraisal of medical literature, where when in 1971, RC Brain instilled the concept of RCTs, but they didn't have some proper method of doing things, and there were a lot of lacunae in the conducted RCTs. So David Sackett tried to analyze them, and then they coined something called critical appraisal, where they went through the entire literature, methodology, their method of performance of that, and all those things, and they critically analyzed, and they found out what are the lacunae in that particular literature and how the further collection of evidence or further conduct of the study with the same particular thing can be improved to make it much more clinically objective and efficient. And thus the concept of evidence-based medicine evolved, and which is nothing but the conscientious, explicit, and judicious use of the current best evidence in making decisions about the care of an individual patient. So this is in a nutshell evidence-based medicine, and rightly David Sackett, R.C. Cochrane, and Alvan Feinstein, these three people are considered as three fathers of modern clinical epidemiology. So let us see, what do you mean by research? Research is nothing but finding something new in the particular field. It may be medicine, it can be engineering, it can be healthcare, it can be agriculture, it can be anything. But you're trying to find something new in the field. It's not necessary. It's not necessary that it should be a path-breaking invention. But sometimes it can be some tweaks or some uh, hacks or something which helps you to do work better, or which help you to manage things in a better way, or which tries to explore the unseen effects of certain medications or certain instruments, or where such kind of things, so which are basically beneficial to the patient. And also sometimes there might be some established interventions, and you may which may have some of the undesirable side effects which are not seen, but however by doing research probably you might end up finding such undesirable effects. And there are certain examples of some drugs which were withdrawn from the market after, for example, a good uh, anti-epileptic agent, which was withdrawn because of its potential effect on the fetus, that is the thalidomide. So these are some of the examples where research helps to find out not only the things which are beneficial to the patient, but also the harmful side effects which are not noticed with some of the drugs. Both, and eventually both of them are going to bring a change in the practice. And finally, whatever research you do, it has to reach its logical end. That is, whenever do a research, you obviously want it to be seen by many people. So how do you see, how do you make that sure, is by publishing. So therefore, by so this entire process of conducting a work, experimental work, and then eventually taking it to the level of publication so that it is shared to the whole world, is the process of research. Once you understand the concept of research, now what are the types of research? Research are basically, right now today I'm going to talk about only the medical research. So we have primary and secondary research. This is a little busy slide, but please, I hope you will be able to see. The primary research can be classified into some basic research. Basic research is basically about the most primitive method of assessing the effect of a particular thing, a particular drug or a particular, where you try to generate a theoretical pattern of doing a particular thing, or analytical measurement of a particular thing, or you find out a new test, you develop a new test to be useful in detecting certain things, or it can be a biometric procedure, imaging procedure, whatever it is, or it can be theoretical and it can be applied in the form of animal studies, genetic engineering, cell study, and in vitro studies. All those things are basically included under basic research, and with that one we are not going to touch upon. And next, and the important one, is the clinical trials, which is of most important for us. Okay, so among the various clinical trials, we have experimental and observational. Okay, in the experimental, most of the clinical trials, experimental clinical trials, are conducted for to study a new drug or anything like that. So this consists of basically phase 1, phase 2, phase 3, and phase 4 trials, where phase 1 is, as I said, it's an animal study. Phase 2 is the study conducted in human volunteers using the drug to understand the efficacy of the drug. Then phase 3, once you understand the efficacy, you apply the same protocol in a larger number of subjects, where you involve not only the volunteers but also the actual patients, and see really the effect and the side effect of a particular drug, that is the efficacy and the safety. So that is known as the phase 3. And phase 4 is post marketing trials, or the once the drug has been approved and it is allowed to be used in a commercial in a routine practice, in our routine clinical practice. Then you again follow up the patients who are receiving those new drugs and find out if they are manifesting some new problems or anything, and report that. So that is known as the phase 4 trial. So therefore, we have phase 1, phase 2, phase 3, and phase 4 trials of experimental clinical trials. The other one is observational clinical trial, where you can do a diagnostic study, you can do a therapy prognostic study. And for us, most of the time, what we are bothered about is the therapeutic study or the diagnostic study, especially pertaining to anesthesiology. Then comes the epidemiological trials. Epidemiological trials, most of the time, they are basically, and these epidemiological trials are the ones which are being conducted routinely by our postgraduates, where, and most of the times it is the post-marketing surveillance, or once the drug is established to be released into the market and it is being used routinely, you try to find out what's going on with that particular drug and how good it is, and if there is anything hidden which is being exposed, or which is being explored these after its marketing. Okay, sorry, sorry for the. So that's about the experimental epidemiological trials. In the epidemiological trials, as I told, we have experimental epidemiological trials, where we intervene by putting something, or some method, or some, in the form of some, it might not always be the drug or the technique. It can be even a simple questionnaire. You submit a questionnaire and find out, or you give them a training program and see pre and post training the efficiency of a particular group of people. So these are the things what are known as interventional studies. where you do some sort of intervention and see how the effect comes out. Other one is the observational epidemiological trials. Most of the time it involves the various types include cohort study, case control study, cross-sectional study, or excuse me, a cross-sectional study where you just follow up the patient and find out what's happening without doing any intervention. You just follow up the set of patients and see how they behave and what happens to them with particular exposure and without exposure of the risk factor. Now, this is about the primary medical research. Then the other thing what we have is secondary medical research. So, which most of the time is review and analysis. Systematic review and meta-analysis. Review, there are two types. One is a systematic review and the other one is the narrative review. Narrative review is nothing but what you see in various conference notes and other things, where the author collects so many data, so many articles, and reads all of them, and he writes what's his opinion based on that particular subject, based on reading the knowledge obtained from various articles. Whereas systematic review is a little more systematic, where they collect the data of so many studies and they mention the results of each study in the form of a numbers, in the form of a tables, and display them. And then with that, on that basis, they generate some conclusion, and that has been discussed. So that is known as the systematic review. Meta-analysis is a step further, where they collect the information of all the various from the various studies from various all these values or results from various studies. They collect it and they do a secondary statistical analysis of those data and finally come to a conclusion based on the statistical analysis. So for all practical purposes, the meta-analysis is the one which is the highest order of evidence in the research, in the evidence-based medicine. So for us, as I show in the bracket, these are the things which are important for us as a clinician. Now coming to the basic types of animal research, already we just discussed about these things. The primary research, again, I told drug trials, interventions, everything comes under clinical trials. Epidemiological trials, basically observational trials, what we come across routinely, we see, we observe the incidence of vitamin A deficiency or the incidence of post-operative nausea, vomiting after a particular method of treatment, or onset of observing the patients, what happens like post-operative recovery following general anesthesia and geriatric patients. These are some of the examples of epidemiological trials. And secondary research consolidates such as reviews and meta-analysis, as I told. And there is something called tertiary literature, where the details from the primary and the secondary literature are all combined, pooled together by an author and provided in the form of a concise information. The examples include textbooks, handbooks, encyclopedia articles, etc. Apart from all these things, we have something called grey literature, where they are basically some sort of literature, but they are not actually useful as a evidence. So examples include your thesis and abstracts of conference places, then conference proceedings, which are more available only for conference participants, and certain things like social media such as blogs, WhatsApp, Facebook, etc. Once you consider the level of evidence, the strength of evidence, if you see, this is a pyramid where you see the meta-analysis and systematic reviews take the topmost form of the pyramid. That means they are the highest quality evidence, and they are considered as the level A evidence. From the level of meta-analysis till the randomized control trial, they are considered as level A evidence. That means whatever results from there is obtained is actually considered to be of very good quality evidence. And whereas case control studies, cohort studies, and other things, and clinical research, or even your auditory reports, all these things come under level B evidence. And whereas case series, case reports, clinical guidelines, expert opinions, editorials, etc., come as level C evidence. And animal and laboratory studies are the last in the base of the pyramid, but they are the important things which give a lot of information, initial information as to how a drug behaves and how it can affect the human body. So again, this is again the same thing, where the type of the study. So once you know that we have, as per pyramid, we have these various types of methods of study. So these methods can be either retrospective, when you collect data from already completed patients, or prospective, where you observe the patient and collect all the data. So again, The last three, that is a court, case control, and case reports, they are basically observational because you don't do any intervention there. Likewise, randomized control trials are the ones where you actually do an intervention and observe how that intervention changes the characteristic of the patient population. So we just quickly go through some of the examples. Now this is an example where a doctor studied a traumatic dental injuries in permanent dentition of 847 patients. And this was conducted in a dental school in Brazil, and the clinical and radiological data reviewed from 2000 to 2008. And this data was collected from the patient's file. They didn't call the patients, but they all collected from the patient's file. And from that, also the patient file, they also collected other data such as the age at the time of injury, gender, permanent tooth type, and to a type of dental injury, what is the cause of injury, and the month when the traumatic dental injury occurred, and what was the root material, etc. So they collected so many data, and the entire class data was classified into 5 categories. Okay. So therefore, what kind of study is this? This is a retrospective study. If you see, because already they are not, all the injury has already happened. What they did was they collected the data from the case sheet and they reviewed all the various parameters, and from there they came to a certain conclusion. So this is known as retrospective study. Next, let us go to the next example where 5 lakh men and women were enrolled in the National Institute of Health Diet and Health Study, and a questionnaire was sent to around 50 to 71-year-old patients regarding their dietary habits of types of meat, what they were eating, and what kind of preparations, whether they were eating raw meat or cooked meat or burnt meat, etc. And they also tried to find out association between CA rectum and lung and also the meat intake. And they observed that both red meat intake and processed meat intake was positively associated with the cancers of colon and rectum. Likewise, red meat intake was associated with an elevated risk of cancers of esophagus and liver. So, what kind of study is this? This is a prospective study where that is because they are observing for the occurrence of the event. They have seen what is they are exposed to, the risk factor, that is a process and the red meat, and they are seeing what is going to cause. So therefore, it's a prospective study. So we now understand what is prospective and what is retrospective. Next, we will move to the next. So in the type of in this study, the researcher used 29 placentas from cocaine users. Okay, so he identified all the cocaine users and collected their placenta, and then 15 placenta were collected from those patients who are matched with regards to their age and sex, etc. And but they were not cocaine users. So they collected 15 placenta from such patients, from such participants, and 29 placenta from cocaine user participants, and then he examined them prospectively, and he actually pathologically what were the pathological findings, he documented that and examined, and he found that the prevalence of retroplacental hemorrhage and chorionic villus hemorrhage, edema, choriamnitis, etc. were more with cocaine users and not the drug-free control. So therefore, what he did was he didn't do anything. He didn't do any intervention. He just collected those two, found he noticed what all changes were there, and he just reported that. So this kind of a study is known as observational study, where he is not doing any sort of intervention. He is just observing what's going on, and therefore it is observational study. Okay, and because he is collecting the data and then prospectively seeing this, it is most often a prospective observational study. So next, this is about another research where 60 children of age 1 to 5 years undergoing subumbilical elective surgeries are taken up, and they are divided into 3 groups of 20 each to receive caudal epidural. So each group, one group received local anesthetic, the other one received local anesthetic tramadol, and the third one received local anesthetic with midazolam. And they were observed for duration of analgesia, motor blocks, sedation score, etc. So what kind of study is this? This is interventional study where you intervene by giving different types of drug combinations into the caudal space. Okay, so this is so therefore it is intervention study. So we finished with prospective, retrospective, observational, intervention. So these 4 things we have covered now. Next, we'll go through the case report, case control, and cohort study. All these things are most of the time observational studies. So let us go to the next term. So a 5-year-old boy was admitted in an intensive care unit immediately after administration of glycopyrrolate because he developed agitation, apnea, hypertension, tachycardia, anuria, etc. after administration of glycopyrrolate. So therefore, they went through the entire gamut of symptoms and they finally come to the conclusion of central anticholinergic syndrome for that child. But the important thing is here, when you go through they did the review of literature, they found that this kind of muscarinic receptors are blocked by more than 600 drugs, not glycopyrrolate alone. And they subsequently, they discussed about the management of the patient. Unfortunately, the child died of other critical events. So what they did was, they just pick up one patient who developed some unusual problem following administration of glycopyrrolate. Okay. And that has been reported, and they have discussed how they managed and what are the causes. And this kind of a presentation is known as case report, because it's a presentation of a single patient, an unusual complication in a single patient. Next is, in the next research, they were trying to study about unanticipated tracheal reintubation in post-anesthesia care unit. So what they did was, they analyzed the records of patients who required tracheal reintubation. Here they are trying to find out what is the cause for this unanticipated tracheal reintubation in the PSU. So therefore, what they did was, they collected all the patients' details who required reintubation in the PSU, and then they went through the records and go on analyzing what all they were received. Then what they did was, they collected one more similar group of patients' case sheets who did not require tracheal intubation. And so therefore, one set of case sheets who required tracheal intubation, the another set of case sheets who did not require tracheal reintubation in PSU, but they are similar to the first patient group in all other aspects except for the fact that they did not require reintubation. And then they checked in which patients in each group had their neuromuscular block reversed. And finally, they come to a conclusion that there was an association between inadequate reversal and reintubation. So what they did, they first went to the effect, that is tracheal reintubation. From there, they went back and to analyze what caused that effect. So therefore, this kind of a study is known as, so the initial thing is the outcome, and then the case in this which resulted in this outcome is the ones who required reintubation. So that's this group. And next forms the control group who did not require reintubation, and eventually this is the causative agent or the exposure, that is the reversal agent. So this kind of a presentation where you moved from the exposure towards the cause or the outcome, what resulted in that particular thing is known as case group, so control group. So therefore they are matched, and eventually this kind of a presentation is known as case control presentation. Sorry. Yeah. From the outcome, you move towards the exposure. So therefore, this kind of a thing is known as case control study. Next, so one thing what we always ensure is the case and the control groups, the demographics and other parameters of the patient should be matched to ensure that the causative agent is this one only. So next is cohort study. So where we are going to assess the patients in the prospective manner. So this case control study is a retrospective study where we followed up from the outcome and we went through the case sheet. Already the outcome has already happened, and from there we trace the exposure. Whereas this is another type of study, that is a cohort study, where we prospectively follow up the patient from the exposure towards the occurrence or non-occurrence of event. So its example is, you are trying to study the long-term effects of diabetic mellitus on microvascular damage. So, the author selected women with prior gestational diabetes mellitus, and then women with previous pregnancy with no history of gestational diabetes. So, this was the case and this was the control. So, those with gestational diabetes was a case, and those without gestational diabetes acted as control, and from them she went on at various time intervals to assess the microvascular function in the form of post-occlusive reactive hyperemia using a device that is a laser Doppler fluximetry, and eventually they recorded the baseline perfusion before on the day of starting of study. Then subsequently they compared various parameters such as baseline perfusion, biological zero, peak perfusion, time to peak, recovery time, etc. All these things were collected, data collected from both the groups over at various time intervals. For example, let us say on the day of admission, and also at 3rd month, 6th month, 9th month, 12th month, and they went on assessing what's happening to the microvascular damage. So this kind of a study is prospective cohort study, where already you are trying identifying those patients who are exposed to the risk factor and those who don't have the risk factor, and follow them up for the outcome to happen, and see how many of them develop that particular targeted outcome and how many of them don't develop that particular targeted outcome. This kind of a study is known as cohort study. As I said, here the pregnancy is the cohort of patients or the population, and those without diabetes mellitus are considered as non-exposed, and those with gestational diabetes is considered as exposed. And among them, the event is the microvascular disease. So you just see how many of them developed microvascular disease in exposed group, and then how many of them in non-exposed group developed microvascular disease, and compare them. This kind of a study is known as a prospective cohort study. And the next is the research type is the randomized control trial. That is, you just where you it is much more streamlined and much more well controlled conduct of a clinical study, where the patients are assigned prospectively by a chance into two groups, that is the experimental and the control groups, and you do some sort of an intervention, and then you find out what's going on. The ideal studies, so for example, good randomization will wash out. The main advantage is that this kind of a thing will wash out all the population bias or population confounding factors which can affect the outcome, and they are easier to blind and mask than the observational studies, because all the subjects are under your control, and the results can be well analyzed with well-known statistical tools. That's the advantage of randomized control trials. So just an example, where intrascalene block for shoulder arthroscopic surgery, prospective randomized control study of effect of 0.5% ropivacaine and 0.5 ropivacaine with dexamethasone. So here it is the intervention is the placement of dexamethasone along with ropivacaine. Next is the review and meta-analysis. This is the best among the study methods in support of evidence-based medicine, because they test with more power than what scope, and they don't have a use specifically mentioned by how they search the literature, and their appraisal is variable, and most of the time it's a qualitative summary of data and without any presentation of data, and sometimes inferences can be personal opinion or sometimes can be evidence based, whereas in systematic review it is much more usually the research question is very focused, and the sources search is very clearly comprehensively mentioned and explicitly mentioned, and the appraisal is very rigorous, and quantitative and most of the time the outcome is calculated, outcome is presented in the form of a quantitative summary, that is in the form of values, and most of the times based on that values only you will be coming out with the inferences. So this is one of the examples, inter and intra hospital patient transfer recent concepts. This is an example for narrative review. They just mention what's based on literature, what the author thinks. Percutaneous tracheostomy, a systematic review. In this review article, you can see they have mentioned the search strategy from where all they collected the data, various search engines, and then they mention all the the articles, what kind of articles they selected, and then eventually whether they have followed, whether they are RCT or observational studies, whether the randomization was followed, allocation concealment followed, blinding was followed, whether intention to treat analysis was considered, or whether they had a predefined outcomes or outcomes were later defined, or was there a baseline impact. So they went through so many aspects. They critically analyze each article, and then based on that they come to a conclusion. So they also mention what kind of like how many patients were involved, what was the inclusion and exclusion criteria, and who did that, and what was the outcome. Next is the final type of article is a meta-analysis, where and based on that you provide your conclusion. So that is about various types of researchers in a nutshell. Now with this background knowledge, so let us now start with some small exercise. Most of the times what happens is, once we decide about doing a research, there is always a little confusion as to which how to select an article. So I would like to suggest a simple thing. So most of the time what we can do is, you need to go through the literature search to find out. For example, let us say you want to do a study on spinal anesthesia, and you have to do a study on geriatric patient. So you usually use those keywords, like for example spinal you can mention, or subarachnoid you can mention, and you can also mention, now you are going to do it on a geriatric patient. You want to do a study on geriatric patients. So I mentioned a word called A&D. Now this, what is this A&D known as? This A&D is known as the Boolean word or Boolean term. So various types of Boolean terms are there, and I'll tell you what is the significance of that. So spinal and geriatrics. So I mentioned like this, and then click. You can see you got 2600 results. Okay, so it's very difficult to go through all the entire 2600 this one. But if you see, they are talking about advanced life trauma, life support, chronic pain in elderly, etc. But so therefore it's not related to anything which is your of your interest. So what I would like to do is, now I'll just change, instead of mentioning spinal, I use a something or some equivalent word. Let us say subarachnoid block and geriatrics. Now I search. Immediately what happened? Your search results from 2000 something went on to 286 results. Okay. So likewise, suppose if I make it, so it includes all the articles which has the word subarachnoid block and also which has the word geriatric. So that way I got 286 results. So once if I mention another Boolean word, that is or, so what will happen? I hope the screen is visible to all of us. Kamachi sir?
Screen is well visible, sir.
You see, if I put subarachnoid block or geriatrics, what will happen is, you can see the amount of results. It is 29,481. So what does this thing do is, it will look for all those articles which has got subarachnoid block as well as geriatrics. It's not necessary that they both should be there in the same article, but if either one of them is there, it will show those articles. So you have epidural and spinal anesthesia. So if you see epidural spinal block, subarachnoid block in prone position, hypotension subarachnoid block, elderly patient. So that way, combined spinal epidural technique. So this way, it shows so many results. Again, this becomes so cumbersome. So I put instead of R, subarachnoid block, not geriatrics. So if I put that way, again it will talk about only subarachnoid block, but no article which has got both subarachnoid and geriatrics. So it will not show those articles in which subarachnoid and geriatric patients are involved. So this is the importance of understanding this, the Boolean terms. So I put again, and you can see the number of results is only 286. So it's easier to read 286 articles. Further, again, I can put the filters like I can select only free full text. So automatically your result further came down to 134. And now I come down on the this one. If you see, this is the timeline. If you see, there are certain publications at this particular period of time, but if you see this entire area, there is no publication. But again, from this point onwards, there are lot of publications in this field. That's what we understand by seeing this graph. And then if I reduce the time, let us say that I want to have the data only for the last 14 years, 15 years. So I further put that filter. So it reduced from 134 to 126. And I have selected only free full text. So now I get only free full articles. So here geriatric patient, again subarachnoid block. So these are the articles which have which are related to my area of interest, that is subarachnoid block and geriatrics. From this I can select the article and then I can go ahead with the my research work. So that's how we usually look or search for our literature. So with this, I think we'll move to the next thing. Is it clear? Am I too boring?
Students can ask questions. So far, any doubts?
Yeah, so this ends the part 1 of my presentation. That is the overview of how literature, and then how do you look for a literature search to make it narrow down your search and to narrow down to your area of interest. Is my screen visible, sir? No problem, no, sir?
Yes, sir. Yes, sir.
So once you decide how you are going to decide upon the study and your topic, so let us say how you are going to implement the research methodology. So we already discussed about various types of study design, that is a descriptive and analytical. Randomized control trials we already told. So in this, if you just see, the basic principle is most of the time the investigator assigns exposures. If he is assigning the exposure or if he is planning for an intervention, then it becomes an experimental study. If the investigator doesn't put into any sort of he doesn't intervene or he just follows the patient, then it becomes an observational study. Okay. Once you know whether it's an experimental study or observational study, next step is the experimental exposure done by a random allocation or by non-randomized allocation? If it is done based on a randomized allocation, that means you generate a random number and based on that you allocate the patient and the intervention, then it becomes randomized control trial. If you don't follow that, it becomes a non-randomized control trial. Now, okay, now coming to the observation part. In the observation study, are you observing only one set of patients or you are trying to observe observe two set of patients and compare between them? Then that becomes the comparison group. Again, if you are in that, if you are doing a comparison, it becomes an analytical study. If you are not comparing, you are just observing and reporting the outcomes, then it becomes a descriptive study. In the analytical study, again, whether you are moving from the exposure to outcome or outcome to exposure in the reverse direction. In case if you are moving from exposure to outcome, then it becomes cohort study. If you are moving opposite direction, that is you have seen already the outcome, from there you are tracing back to see what is the exposure, then it becomes case control study. If you are studying exposure and outcome, how many of them are exposed and how many of them had outcome at one particular point of time, at this one point of time, that is known as the cross sectional study. So these are the various, in a nutshell, various types of studies, whatever we discussed so far. So now the simple thing is, you will know, you might always have this thought in your mind, like what kind of a study question and what kind of a study design I need to take. So suppose if you are doing something like a burden of illness, let us say example, what is the incidence of tracheal intubation following in a OPCP compound, or what is the incidence of nausea vomiting following administration of intrathecal morphine, or what is the incidence of let us say post-dural puncture attack following spinal anesthesia with 25 gauge spinal needle. So here what you are trying to find out is, with your intervention, how many of them are going to have a problem. So this kind of a study generally can be done by using field surveys or a cross-sectional survey or a longitudinal survey. Next, you are trying to establish cause, risk, and trying to prognosticate a particular risk factor. Let us say you are trying to establish a cause between smoking and post-dural puncture attack, or you are trying to establish a cause for smoking and post-operative pulmonary complications, or you are trying to establishing the correlation between pan eating and the incidence of post-operative nausea vomiting. So when you are trying to establish such kind of a things, you can either go for case control study or cohort study or randomized control study. So any of these things are possible. Okay. So for example, as I told, pan eating, etc., you cannot make them as an intervention. Only thing is you can just follow them as a cohort. Like those, you just select those who are eating pan and those who are not eating pan, and then find out what's going to happen in them. How many of them develop PONV, how many of them don't. So that becomes a cohort study. Or you take all the patients who had post-operative nausea vomiting and then go through their case records and find out how many of them were taking pan and how many of them did not take pan, and that will result in case control study. Okay. And finally, treatment efficacy. This is what we are seeing most often. That is the treatment efficacy, and that is known as randomized control study. And diagnostic test evaluation, for example, efficacy of your ultrasound airway assessment or your efficacy of Mallampatti, etc. If you are trying to assess the diagnostic efficacy of those various assessment parameters or lab tests or anything, it's better to go for randomized control study. Finally, if you are doing something for cost effectiveness, again, the answer is randomized control trial. So most of the time, this is what we are focusing on in our anesthesia practice, in day-to-day practice. So that is the treatment efficacy, and it's always better to go for randomized control study in that situation. And the next is the prevalence. Next other common thing what we do is the prevalence or incidence of nausea vomiting, incidence of post-operative pulmonary complications, incidence of death following ICU admission, etc. So that can be done most of the time using cross-sectional study. So once we are done with this one, we generate a research question. That is, we go through the review of literature. We have to find out what are the deficiencies in the or lacking in the literature, and try to find out generate a research question. So once we generate a research question, the next thing is to see whether in the research question, whether it has to answer two important things. That is, whether it satisfies the finer criteria and PICOT criteria. The research question should contain a set of parameters that is known as the PICOT, and it should satisfy a criteria known as the finer criteria. Okay. So what are these two criteria? That is finer and PICOT. We'll just go through it once again. Sorry. sorry for the once based on the literature review and etc. we generate a research question. So when a research question is generated, it has to satisfy, it should contain certain parameters that is defined by the PICOT criteria, and it has to satisfy another criteria known as the finer criteria, so that only then you can do that, you can you can conduct that research question in your institute. So what is that PICOT criteria? We'll just go through that PICOT criteria now. So PICOT stands for, P stands for study population. So the research question should contain the sample of subjects who are going to be recruited for the study. For example, as I told in my earlier example, if you are doing a study on geriatrics and and subarachnoid block, so the population there will be the geriatric patient. Likewise, if you are doing a study on cesarean section, so the population has to be pregnant women. Likewise, if you are doing a patient, if you are doing a study of, let us say you are doing a study of some regional block on laparoscopic surgeries, obviously the patients or the study population would be all the patients who are undergoing procedures under laparoscopic surgery, under laparoscopic technique. So that is the study population. Next, it should contain the intervention. So whatever intervention you are going to do, that has to be specifically mentioned in the research question. At this point, I'd like to tell that the research question is not same as the study title. Study title can be changed, study title can be modified a little too, but it should totally convey the research question, and it should convey all the important key parameters that are present in the research question. So research question, it's not always necessary to be a study title, but research question is a question on which you start your entire research, and therefore the research question should contain all these details mandatorily. That is, number one is study population, and next is the intervention that is to be done. Okay, and next is the control, or the control against which you are comparing it, or the comparator arm. So you should have a study population arm and a control. You should also mention about the control arm, and also you should mention about the intervention to be done. And O stands for outcome. That is, what outcome you are going to study. That should be, or what is your primary outcome. That should be clearly mentioned in the research question. And finally, the time, or the time, it is it. T stands for time of measurement of outcome. It describes the duration for which the data is collected. Now, with this, we can just, I'll just put a question. Let us say I was searching for a geriatric study, and I wanted to do a study on subarachnoid block in geriatric patients. So I want to do a study on subarachnoid block. So I did, geriatric patients are routinely receiving subarachnoid block. But what is new? So when I went through the literature search, and when I went through the thing, and they found that in geriatric patient, what is the incidence of spinal anesthesia following administration of, let us say, some adjuvant, let us say clonidine or something. So that is what is deficient in the literature. So my study research question would be effect of clonidine, addition of clonidine to bupivacaine for subarachnoid block in geriatric patients undergoing surgeries under spinal anesthesia. So if you see this, this research question, we can slowly, if you bisect it, so you just see whether PICOT is satisfied in this research question. So what is the population here?
You just kindly unmute yourself and answer.
If any, yeah, you people can unmute and answer. Okay, the population, study population is the geriatrics, and then what is the intervention? So intervention is addition of clonidine, not spinal anesthesia. So mind you, here the intervention is addition of clonidine. Understand? I am adding a new drug and seeing what is the effect of that on hypertension. Okay, so therefore intervention is addition of clonidine to intrathecal drug as an intrathecal drug. And who is the control arm? all those patients who receive spinal anesthesia without clonidine will be the control arm. Have I mentioned that? So I have clearly mentioned effect of addition of clonidine to bupivacaine. So therefore, those who receive clonidine and bupivacaine will be the intervention arm, whereas those who don't receive clonidine will be the control arm. And then what is the outcome? Outcome is, I told, the effect of this on incidence of hypotension. So therefore, the incidence of hypotension will be the outcome. And then the last is the T, that is timing of measurement. We are in this, because we are talking about subarachnoid block, it is implied that you are talking about the intraoperative period. So therefore, it's not always necessary that T has to be mentioned in the T has to be incorporated in the research question. But if you are doing it in the post-operative period or 3 months, or the incidence of let us say you are doing this, you are finding out the incidence of hypertension in the 5th month or 3rd month or something like that, then you have to specifically mention that in the research question. So therefore, a research question should contain all these population intervention control, outcome and timing T, that is PICOT. It should contain all the PICOT thing. And then second thing is, it has to satisfy the finer criteria. Now, what do you mean by the finer criteria? So F stands for feasibility. That means you are planning to do a study on geriatrics and spinal anesthesia. Your institute should have enough number of patients who are geriatric patients, and you should have enough number of patients who you can conduct study upon. And not only patients, but also there should be other sufficient resources, that you should be able to have a you should have a BP monitor to monitor the BP. You should have the good sufficient resources in the post-operative period to follow up with regards to hemodynamic parameters and also incidence of hypotension. Likewise, you should have enough surgeries being done in geriatric patients, and also you should have enough time to sit and analyze all these patients, or you should have reliable nurses who go up, who see the patients and who manage everything. So that is the feasibility criteria. That means that study should be feasible in the place of your work. Next, it has to be interesting. That is, as a researcher, it should be interesting to not only to you, but also this should be interesting to the person who is going to read this particular research. So that is about interesting. Next, novel. Novel, it has to find something new, or it might be sometime in confirming whatever is the preliminary finding, or it might refute the for example, somebody would have done a study, and consistently everybody were told that clonidine at a particular dose is going to enhance analgesia. Now, in your study, there should be something which you have noticed, and you have found a study which is you have found an observation which is opposite to it. It should be uh, opposite to the what is existing in literature. So that kind of thing. So there should be something new in your study. So therefore, that is novel. And most important thing is E stands for ethical. That is, it should be perfectly following the ethical guidelines, and it should have all the regulatory approvals from the institutional review board and all other ethical committee boards and other boards as deemed necessary. And finally, R stands for relevant. Relevant means it should be useful in the present day practice, present day clinical practice, and it should be capable of influencing the current clinical practice, and also it should lay a platform for future research and also health policy. So therefore, whatever research question you frame, it should actually satisfy the finer criteria. It should be feasible in your place, it should be interesting for you and for the person who is going to read, and it should have some novelty, it should have something new information. And next, it should be ethically followed, it should have it should be based on ethical principles, and finally it has to be relevant. Yes. So we were just discussing about the PICOT and the finer criteria. So I'm just using the one of the dissertation topics that has been given. So in this, the title of the topic is comparison of oral clonidine versus oral moxonidine on sensory and motor characteristics of subarachnoid block. So with this, the objective study is to study the effect of oral moxonidine on onset and duration of sensory block, duration of anesthesia, and hemodynamic parameters. These are the things what I am going to study. So before that, so we just see whether it satisfies the PICOT criteria. Okay. So the here the P stands for population. The population is all the patients who are undergoing, adult patients are undergoing subarachnoid block or surgeries under subarachnoid block. So P, and next I, intervention is administration of moxonidine, oral moxonidine, and C is the comparator, that is oral clonidine is the comparator. And then what is the outcome? Outcome is the sensory and motor characteristics of motor characteristics. And T, we very well know that it's an intraoperative study. So it lasts, the study duration lasts for only 24 hours. So that's why it's not specifically mentioned. Next is finer criteria. So is it feasible in my institute? Yes, because I do a lot of patients. So we do have a lot of patients who undergo anesthesia under subarachnoid block. So therefore, it is feasible. It's interesting because I am trying to find out a drug which is used as primarily as an antihypertensive and exploring its analgesic properties. So therefore, it's interesting. And is it novel? Yes. Oral clonidine is an established fact, but however, moxonidine, which is a congener of clonidine and which has got a better side effect profile, has never been assessed for its effect on regional anesthesia. So therefore, it is novel. And whether it is ethical, yes, because both of the drugs are being routinely used in the management of hypertension in renal failure patients. So therefore, I am not doing anything unethical. So therefore, and we all know what are the effects of these two drugs. So therefore, there is no ethical problems involved here. And finally, whether is it relevant? Yes, it's relevant because moxonidine is rarely practiced in the field of anesthesia. So therefore, it contains all the parameters of the PICOT and also it satisfies the finer criteria. So that's how the research question has to be. So when we start off writing a dissertation, so it consists of the title of the topic. This therefore the title of the topic should be actually very clear. It should be equivalent to the research question as far as possible and should satisfy the PICOT and finer criteria. And objectives has to be clearly mentioned. What is your objective? Primary objective, what is your secondary objective? And it should contain all the parameters. So once you comes to materials and methods, you have so many source of data and methods of how to collect. So here, the source of data invariably will be the hospital. Now we come across various other parameters, that is the study design, study period, place of study, sample size, etc. These are the things which form the methods of collection of data or your study proper. Now, what do you mean by each of these is what I'm going to deal in the subsequent slides. Then we have certain things called inclusion and exclusion criteria, which decides what kind of a patient will be included in our study for the sake of removing all the bias and also ensuring the uniformity. And then we describe the methodology proper, where you are mentioning what exactly you are doing, how you are enrolling the patient, and how you are giving, when are you giving the intervention, and how are you following them up. So what all tools are you are using, or what are the assessment tools you are using to follow them up? For example, in the form of how do you assess the sensory blockade? What is the duration? How do you assess motor blockade? What are the parameters you are going to assess? These things are known, and you define them in particular sentences. So these forms the assessment tools, and then you define each and every parameters with each assessment tool is defined using a definitive definition so that it is uniformly applied in all the study participants. And finally, so whenever you make a synopsis like this, and some of the major issues what you face is you don't have a pilot study, you will have to do a pilot study. Then you have to include, and you should have a proper inclusion exclusion criteria, and also recruitment targets, how many patients to be recruited and how to in what methods you have to recruit, then how to you standardize the data collection instruments, then what all measurements tools you have to use and how to access to be used, and how do you plan for a statistical analysis, and and how do you ensure that there is a good quality of data collected, and you always are assured of a quality data at all levels. This is about the basic or basic problems faced when you are generating a synopsis or when you are starting a research. So the first thing among them is the pilot study. So when you try to do a pilot study, now why you want to do a pilot study? Most of the time it is to check out the feasibility and check out what are the deficiencies in the methodology and assessment tools or study parameters and iron them out, and to iron out minor practical issues in data collection and entry. Many times you might have put in a particular format of collecting data and you find that that is not very useful or that's not collecting all the information. So you might have to do some minor tweaking in the data collection format. So those things can be attended to by doing a pilot study, and also you can standardizing the monitoring methods and tools, and also you can make other people aware of what kind of a study protocol you are using so that they all can do it in a proper way. The study area you have to describe, and it most of the time involves the location of the study, which most of the time is hospital in our clinical practice, especially when as long as it's anesthesia is concerned. And the study period is from the time of recruitment of the patient till the last data is collected. So what is the maximum period that you are going to use for completing the data collection and completion of study? You have to define. Then you have to select the appropriate study design. Already this study design we discussed, that is whether it's a prospective, prospective, retrospective, whether it's a cohort, or whether it's observational, or whether it's an interventional study, or whether it is again, if it is observational, whether it's cohort, case control, or cross-sectional study, or if it is interventional, whether it is randomized or non-randomized control study. So you have to clearly mention that, and then selection of study population should be clearly based on the proper inclusion and exclusion criteria. You should clearly lay down the proper inclusion and exclusion criteria for including the study population, and then you already have a prerequisite for study. That is, what are the study tools? Study tools means it's not only about using the objectives, objects such as BP apparatus or anything like that. It can be anything. It can be your VAS score if you are managing pain. It can be your some PONV score, or it can be a questionnaire if you are doing a survey. So those are various things whatever you use to collect the data are known as study tools, and you use various terminologies. For example, as I showed in the previous slide, you use certain definitions such as onset of analgesia, duration of analgesia. So you explain them and you clearly lay down a clear understanding of each terminology. What do they mean in the study parameter, in the study methodology proper itself? And also you use various orientation trainings to various your colleagues to appraise them about your study and how you are going to do, and how you are going to do the methodology, and how the data has to be collected, etc. So these are the various components which comprise the methodology section. And then, as I told, study tools for data collection has to be planned. So what are the study tools? It is basically the patient's details, a proform which contains all the details, and then various examination methods where you explain, like for example, you mentioned that the BP is measured in the left upper limb using a automated manometer at 5-minute intervals. So where you clearly mention what kind of examination you are doing and how you are taking and what measurement you are taking. And in case if you are doing any blood investigations, you are clearly mentioned about various blood investigation. And then the next is the planning, like what kind of data collection, compilation, data entry, and analysis plan. How you are going to statistically analyze the whatever data is collected. And finally, and most important, is the confidentiality and ethical clearance, which has to be mentioned in your synopsis. That is, whether how you are going to ensure the confidentiality. That is, you are ensuring that the patient's name, patient details are not given. It's only the data values what are given, and then what kind of this thing, how you are going to safeguard the patient's identity, etc., has to be clearly mentioned in the methodology in the synopsis. Likewise, uh, ethical clearance, how we are going to apply for ethical clearance, and what you are going to whatever other clearances. For example, if you are doing a study using nuclear materials, then you will have to take help of you have to take clearance from Baba Atomic Energy Committee, like that. Each for if you are doing an animal study, you have to take from animal board, clearance from animal board. So those kind of things what you have to clear, all those things has to be mentioned in the methodology. Coming to the methodology, now how to select a patient is known as the sampling method, and then how many patients how many patients you want to include in the study, that is known as, that is explained by the sample size estimation. These two differences you have to clearly understand. So, and how to ensure standards, you do randomization, allocation, concealment, blinding, bias, and confounders. So these are the things which form the components of your methodology. And then how to make good data reporting. So you collect the data in a proper application. You clearly mention what kind of pro forma you used for data collection, what all parameters you use, how often do you collect the data, how often do you make the measurements, and then how do you apply, what kind of proper statistical methods you apply to do the study. All those things you have to mention in your methodology part. And then with regards to subjects and participants, what are the criteria for inclusion or selection, and how do you exclude the patient? One thing I always want to mention at this point is, whenever exclusion always comes after inclusion. So for example, let us say you are doing a study on spinal anesthesia. You recruit all the patients who are fit for spinal anesthesia for in your study. Then you see what are the inclusion. For example, you cannot include all the patients in your study because you have to have certain common parameters in both the groups. So you enroll only those patients whose age is between 80 to 60 years, and then you involve only those patients who are belonging to ASA grade 1 and 2. You don't want to, though you give spinal in ASA grade 3 and 4, you don't want to involve them because they are going to influence the outcome of your study. So therefore you select only ASA grade 1 and 2. So all those things has to be clearly mentioned in its inclusion. And once you are included, only then you think of excluding them from that included date patients. For example, if you are including ASA grade 1 and 2, that means you are not including ASA grade 3 and 4. So therefore, you need not mention that ASA grade 3 and 4 is excluded. Once you have mentioned that the inclusion is only ASA grade 1 and 2, it means that you are not going to include ASA 3 and 4. So therefore, you need not mention that in the exclusion criteria. Understand? So that is what I am trying to tell. Inclusion is only after, exclusion is only after inclusion of the patients into the study group. Then once you are included, once you have collected the number of patients based on inclusion and exclusion criteria, how they will be allocated into intervention as well as the comparison groups. And this is known as, by a procedure known as randomization procedure. That means you randomly, it's not necessary that all the patients should be included in intervention group only, or all the patients should be included in comparison group only. You just randomly pick, like for example, the first patient will go to intervention group, 2-3 patient will go to X-ray control group. Again, 5-6-7 will come to experimental group. 8-9 will go to comparative group. So that way, some randomization sequence will be followed, and that can be, which has to be mentioned. And what are the criteria if somebody discontinues the study? Why you discontinue has to be clearly explained in the methodology. And describe how, when, and where the observations are clearly made, and also describe all the instruments and some tools that are to be used in the study. For example, you might use a questionnaire, or you might use an interview, or you might use a laboratory test or clinical examinations, where you have to describe various gadgets or procedures what you are going to use. In case if you are doing intervention, you can go through the drug literature and other things for various regulations, etc. So now coming to the sampling techniques. So sampling is nothing but selecting a group of people from a larger population. So therefore, the study outcome can be extrapolated to the larger population group. And sample size most of the time has to be adequate. If it is not adequate, it can have, if it is over or if it is undersampled, then it has its own consequences regarding the outcome of the study. This is sample which I am going to elaborate in the subsequent slides. Now, again, the sampling can be classified into probability and or random sampling, or non-probability. Non-probability means you just select the patient based on, as soon as they come to the theater, you just select them to the study. Whereas the probability sampling means there is always a possibility of a patient, equal chance of a patient to go either into experimental group or control group. Whereas in non-probability, there is nothing like that. They invariably go into the experimental group only. So therefore, non-probability sampling is applied only in case of rarer condition, rarer diseases or rarer conditions. Whereas probability sampling is the one which is most often followed by us, or random sampling. So probability samples, most of the time it forms a solid scientific basis, and it the gold standard for generalizability of the results by doing probability sampling. And it is also capable of helping us to compute the statistical signal and confidence interval in a proper, more authentic way. So various types include simple random sample, where you just take all the patients, for example, and then divide them into group A and group B on a random basis. Like let us say patient 1, 2, 3 will go to group A, patients 0, 5, 6 will go to group B, and 7, 8 will go to group A, and 9 will go to group B. Again 10, 11, 12 will go to group A, and then 14, 15, 16, 17 will go to group B. So they randomly go on putting like that. There is no particular rule followed. Next is systematic sampling. That means where, for example, every fifth patient coming to you is going to get enrolled in the study, or every second patient is coming to you is going to get enrolled in the study. So that is known as systematic sampling. And next is stratified random sampling. This is, for example, you are trying to do a larger study and you want diverse population to be included in the study for better results. So therefore, let us say an example where you are studying the effect of stress on school students. So you want to understand how the students behave at various ages. So you take 10 patients from class 1, 10 patients from class 2, 10 patients from class 3, which again is random. You don't select like 1, 2, 3, 4. You randomly select student number 5, student number 8, student number 10, student number 15, like that, from each class, like class 1, class 2, class 3, class 4. So this kind of selection is known as stratified random sampling. So therefore, you get different state of patients for the study. Next is cluster sampling. So cluster sampling is, for example, if you are doing a study on Bangalore city, or let us say Chennai city. So you take one set of patients from Nungambakam, one set of patients from Gindi, one set of patients from Mount Road, one set of patients from some other place. Like that, you take a little from each place, and eventually you enroll them into the study. So this kind of a selection of patients is known as cluster sampling. So this is based on geographical, whereas this stratified random sample is not based on geographical area, but within the same geographic area, different state of people. So just an example for simple random sampling, effect of all consecutives posted for fracture femur. Okay, now this is a study which I am conducting to understand the effect of femoral nerve block on pain relief. So if I do simple random sampling, that means all consecutive patients who are posted for fracture femur, I'm going to select for study sampling. Selecting for study. So that is known as simple random sampling. Suppose if I select every third patient who is having fracture femur for my study, this becomes systematic random sampling. If I take among all these fracture femur patients, I take 5 patients with diabetes, 5 patients with hypertension, 5 patients aged more than 70 years, 5 patients aged less than 40 years, like that, that becomes stratified random sampling. So this is a common thing. And once this randomization once we select this kind of sampling, then we do a randomization. That is, this is the process of ensuring uniform distribution of patient characteristics in study groups. And this is one of the most important things to remove the selection bias. So you just this random number table, you select any random number of random numbers, and then you allocate all even numbers to group A and all odd numbers to group B. So eventually it's something like this. See, 1, 3 A group, and again 9 is B. So here what I've done is I've selected I've selected this particular set of numbers, and then I've put like a group A for all numbers which are less than 4, and anything between 5 and 9 I put B. So 1, 3 A. Now this is 9 is more than 5, so it becomes B. So 6 is more than 5, B. Again 2 is here, so I put group A. So this will be the sequence. So the first patient will go to group A, second patient will go to group A, third patient will go to group B, fourth patient will go to group B, fifth will go to group A, sixth will go to group B, seventh will go to group A, eighth and ninth will be going to group A. So this is how a list is produced. This is not a simple randomization. Or in other words, if you find this kind of a allocation difficult, you can also go to certain online softwares also. For example, randomizer.org, etc. And you just feed how many patients you want in group A and how many patients you want in group B. Automatically, it will generate a sequence and give you the sequence. See, this is what I was telling about, where I set as the smallest value of 1, largest value of 6, and I want them to fall into 2 groups. And once I mention that and enter group, these parameters I mentioned and then enter, this is the sequence I got. See, 13, 6. So, for example, 13th patient will come to group A, 6th patient will go to group B, 1 will come to group B, then 2 is coming to group A, and 5 is coming to group A. 4 is going to group B, 3 is coming to group A, then again 6 is coming to group B, 7 is coming to group B, 8. So this kind of a random generation is generated, and we can use this random generation for randomization sequence. This is an example for stratified randomization already explained. Now, once we do a randomization, next is allocation concealment. What do you mean by allocation concealment and why is it? Basically, whenever we do a study, for example, let us say we are doing a study of, I'll just take the previous example, fracture neck femur, posted for femur surgery. I'm trying to study the efficacy of femoral nerve block. So I recruit one patient based on randomization. Patient number 1 comes into the OT. Now I see that his fracture femur, this patient's femur is broken at 2 places. He has got an intertrochanteric as well as a shaft femur also. So then I'll tell my junior, okay, this patient has got a complex fracture. So we'll not give, ideally he's assigned to receive femoral nerve block as per the group allocation. But because this patient has got 2 fractures, I tell, okay, today don't want, we'll give him, we'll make that as a control group. So what I'm doing here is I'm violating the randomization and I'm trying to put in a bias, that is selection bias. I'm personally intervening and doing a selection bias. Now, how I can avoid this? What I can do is I can just ensure that you I generate an allocation sequence by randomization number and then put that in a envelope which is opaque and which is labeled in the serial numbers like 1, 2, 3. So patient number 1 comes, I shift the patient inside the OT and plan the intervention. Then only I open the envelope and see which group he belongs to. And once I open, I just follow that intervention only. So therefore, the person who is going to perform the technique doesn't have a prior idea of what the patient, which group the patient belongs to. So this is known as allocation concealment. So basically, this prevents a lot of selection errors as well as the bias caused by inappropriate patient selection. Apart from that, we can, now this is one part. Apart from that, whenever you do a study, there are so many other systematic errors that can be cropped up in the study. One is a selection bias, which can result in imbalance in baseline characteristics, processes involved in selecting subjects of the study, and loss to follow. Measurement bias in the form of the patient might not report the data properly, or sometimes ascertainment. That means you go and ask the patient in a negative or positive way, which will influence the patient's reply. Or performance bias is, for example, you don't record the data properly. For example, in patient 1, you use manual BP, and patient 2 use automated BP, and again patient 3 use manual BP. So what happens? Obviously the reading keeps on varies because you are using a different type of tool for each patient. So that is about allocation concealment and as well as randomization. Next is blinding. So various types of blinding, of course, single blind, double blind, triple blind is there, but this is not followed anymore. We don't tell that single blind, double blind, or triple blind. We just mention who are all blinded. Blinding is nothing but it's a process where the intervention is not being revealed to the person who is receiving it or the person who is doing it. Okay, for example, let us say you are doing a study, bupivacaine clonidine versus bupivacaine fentanyl. So you mix the drug beforehand and you keep it in a tray in identical syringes, and then you tell the person who is performing spinal to take the drug and give. He will not have an idea as to what is the drug combination that is there in that syringe. Okay, so that is the thing that is known as blinding. So if the person who is receiving spinal anesthesia is blinded, then it becomes a single blind. If the person who is giving spinal also receiving spinal, both of them are blinded, it becomes double blind. And if the person receiving and giving spinal, also those who are recording the parameters is also blinded, then it becomes triple blind. So that way, how much ever blinding is possible, it's always advisable to do as many blinding as possible. So blinding is not, there are certain instances where blinding is not possible. In that situation, it's always better to standardize the treatment in both the groups and also use objective measures where somebody has to just write down and they cannot tamper with the readings from the objectives, and use of consider duplicate assessment. That means two people recording the parameters at the same time, and also you can acknowledge that blinding could not be possible, and this is one of the major limitation of the study when you publish the study. So what is the difference between blinding versus allocation concealment? The allocation concealment ensures that the treatment to be allocated is not known before the patient is entering into the study, whereas blinding ensures that the patient and physician is blinded to the treatment after the patient and gets enrolled to the study. So that is the difference between blinding and allocation concealment. And once you done with all these things, then you load on the proper protocol, iron out all minor deficiencies, ensure standardization of treatment tools, and then proceed with the study. And always, most important thing is the honest and unbiased follow-up and reporting. So basically, use a proper pro forma, ensure that there is adequate space for entering patient demographic and hospital information. All the tools and assessment parameters should be ensured in the pro forma, and also proper support in the form of grading and tables. Everything should be provided in the pro forma along with that, and also mention secondary outcomes in the both synopsis as well as in your present in your pro forma. Use a common standard equipment throughout the study, and do not add new things amid study, and always validate the tool of standard with standard equipment if you are trying to use a new equipment and for the first time. Ensure that the scales used to measure data are always validated. For example, VAS scores are validated scores. Like if you are using some other new pain scale for assessment of pain, it has to be validated against VAS scores and found to be equally efficacious. Then only you have to use. So that way, it should always be appropriate and validated. So it's always important that you should be honest and unbiased. There should be an honest and unbiased follow-up and reporting of all the data. So there are certain terms called bias. Bias is nothing but a systematic tendency of any aspects of design conduct. So there is a tendency in any of these levels. For example, at the time of study design or during conduct of the study analysis or interpretation of the result, there is always a possibility that there is always a possibility that the observation deviates from its true value because of some systematic error that has crept up in the performance of the study. Okay, or there might be some other patient inherent factors which we have not noticed, and that has caused a difference in the outcome. So that kind of a problem, whatever comes, is known as a bias. So it can be by the patient, it can be by the physician, it can be by the statistician, it can be by anybody who does bias. So selection bias can result in, as I told, and how to avoid these bias: use a proper random allocation, and also to ensure that allocation concealment. For reporting bias, you have to collect all the information in a clear and legible manner. It can be due to observer also. Observer has to ensure that you use the proper standard parameters and standard equipment in all the patients to collect the data, so that there is no difference in data, and that is not going to cause an error in the outcome recorded. Confounding factor is one more thing what we have to keep in mind. That is, for example, we always think that there is a direct association between characteristic of a study and the disease. But there is one more factor which is there, X, which can influence both the characteristic as well as the outcome. And this is known as the confounding factor. For example, we are trying to do a study on coffee consumption and pancreatic cancer. And we all know that, all those patients who are consuming coffee are also smoking simultaneously. So the smoking can affect on also coffee consumption, because when somebody smokes, invariably he'll have a coffee in his hand, so he'll try to drink coffee as well as smoke simultaneously. And also they are also prone for developing pancreatic cancer. So however, if this is not studied, invariably we are unnecessarily going to link coffee consumption with pancreatic cancer, which is not a correct thing. So this is known as the confounding factor, and as far as possible we have to remove all the confounding factor by doing by meticulous planning of inclusion and exclusion criteria. So pre-randomization, if the confounding variable is there, then you can negate it by randomization procedure. And after randomization, if confounding variables influences the outcome, that can be removed by blinding. So therefore, it's always better to follow blinding, allocation, randomization, allocation, concealment, and blinding in all the studies as far as possible. So with this, the only thing left out is, at this point, we decided like how to write that, how the methodology goes and how it proceeds. So now one important aspect is the calculation of sample size, because we should know exactly how much is the sample size. So whenever we calculate a sample size is nothing but the minimum number of patients that is required to conduct a study, and beyond that number of subjects, adding more subjects will not change the outcome of the study, will not change the direction of the outcome of the study. So that is how we define sample size. There are two problems why we require adequate sample size. If we undersample, many times the study might not achieve the adequate statistical significance, and the result may not be consistent when the trial is repeated, and it always can result in a questionable validity of the results. However, if there is a larger sample size than what is calculated, it can result in a abnormal depiction of statistical significance, even if the clinical significance is minimal. And second thing, there is an unnecessary exposure of the population to a new drug, to the unknown effects of the new drug, and also it can result in greater economical and ethical burden. So therefore, the sample size has to be adequate, and it has to be calculated for even for descriptive and retrospective studies. So what are the considerations to keep in mind when you calculate sample size? First thing you have to keep in mind. So as we know, whenever we cook food, we keep all the ingredients beforehand, and then only we light the stove, isn't it? So therefore, there are certain ingredients which you have to know before you calculate the sample size. Number one, the study design, whether it is a parallel or crossover. Parallel means group A and group B receive different interventions throughout. Then we have something called crossover, where group A, there's only one group of patients, so they receive drug A in the initial part, and then small period break, and then they receive drug B. So the same set of patients will experience both the effects. So that is known as a crossover. So by knowing this, the sample size also varies. Next is null hypothesis, where you should know what is the hypothesis of your study, whether it is null hypothesis, where you assume that there is no difference between the study and the control groups. Likewise, or an alternative hypothesis, where you assume that there is a difference between the two groups. So this is null hypothesis versus alternative hypothesis. This also we have to keep in mind. And what are the prerequisites? One of the important thing is, whenever you decide upon a study, you should always think of one primary outcome measure that which is reflected in the primary objective of your study, and the same thing should be there in your research question as well. So there should be one primary outcome measure. For example, if you are doing a study on post-operative analgesia, the outcome measure can be duration of analgesia or 24-hour analgesic requirement or anything like that. Likewise, if you are doing a study on a drug on an ICU outcome, the primary outcome measure can be duration of ICU stay, or duration of mechanical ventilation, or anything like that, or even incidence of mortality, etc. Once you define what is the primary outcome measure, you define them in the quantify them in the form of numbers. In case if you are using uh, the numerical values, then you can express in the form of mean and standard deviation. If you are using the based on the incidence, you can represent in the form of proportion. For example, incidence of P and V. So just one group exercise to just break the monotony. Now I am doing a study of effect of dexmedetomidine on intubation response. What can be a primary outcome measure? What all can we think of as a primary outcome measure? You can mute and answer. You can consider changes in heart rate as one of the primary outcome measure, or even changes in systolic blood pressure, changes in mean arterial pressure. Any one of them can be considered as a primary outcome measure for calculation of sample size. But that has to be distinctly mentioned in your study synopsis that you have used this particular parameter only for calculation of sample size. Next, we'll go to the next example. Comparison of sciatic nerve block versus epidural for postoperative analgesia. What can be the postoperative outcome measure? It can be time to first post-op analgesic. It can be 24-hour analgesic requirement, or you also take time to mobilization because you are worried about the motor blockade. You want somebody who's want to walk faster, isn't it? So whether sciatic nerve block helps faster recovery or epidural helps faster motor recovery, that can also be studied, isn't it? So that way you can select whatever is required for your study based on a research question as one of them as the primary outcome measure. So we'll just go through the other things. Next prerequisite is you should assume an effect size. Now, what is that effect size? Effect size is the minimum difference that you are going to study between the two groups. For example, if you are doing a study of on duration of analgesia, you can, what is the minimum difference between group A and group B, what you are anticipating or what you are expecting to happen to say that it is clinically relevant. This is one of the important prerequisites. So you have to assume an effect size. So how do you obtain this value? Most of the time you can obtain it from a pilot study or a previous studies or an expert advice. Most of the time your guides can be help you to find the minimum effect size. So for example, analgesic, if you are doing a study on analgesic efficacy, let us say comparison of epidural versus sciatic nerve, you say that epidural is better than or equal to better than sciatic nerve block. So to say that it is better, the duration of analgesia between the two groups has to be minimum of 30 minutes. Okay, to say that it is significant. So that is the effect size what you have to assume. It's a basic, I'm repeatedly telling you that this is one of the assumptions what you are going to make. Next is the variance or the degree of deviation from the midline parameter what you're expecting. Again, this is also obtained from pilot study or previous studies, and also the standard deviation. And most of the time, we use standard deviation for the continuous variables as one of the prerequisites. Now, I just need to tell an example here. Suppose if you are comparing the duration of analgesia with you are comparing the duration of analgesia between two drugs, and with drug A, in two studies you observed that the duration of analgesia was 235 minutes and 365 plus or minus 60 minutes. Now this 30 minutes and 60 minutes is the variance what you observe. So now how do you want to now how do you come to a conclusion as to what variance you have to enter in the formula? So what you can simply do is you take the average of these two and use this as a variance to be entered in your study, in your sample size calculation. So likewise, this is an example. Whereas, so you are trying to compare morphine versus placebo for post-op analgesia. The previous studies, the duration of analgesia with morphine in one group was 450 plus or minus 65, and other group it was 385 plus or minus 85. So what is the variance to be entered in the formula? You just take the average of 65 plus 85 and divided by 2. So you will get 75 minutes. This is what the value what you are going to enter in the formula in the place of variance. The other prerequisites include two errors, that is type 1 error and type 2 error, which you have to assume. So type 1 error is, or alpha error is nothing but the error where null hypothesis is rejected when it's true. That means when actually there is no effect with the drug A, you assume, you feel that there is a effect. So that means actually there is no effect, but you think that there is an effect, and this is known as alpha 1 error. It represents the chance of a researcher detecting a difference between the two groups when in reality no difference exists. So this is known as false positive. Okay, so you are actually, this is a very dangerous situation, isn't it? So actually the drug doesn't have any effect, but still you think that the drug has an effect, and you give that all to all the patients, and the patients are exposed to the unwanted side effects of that particular drug. So this is more dangerous. Next is type 2 error or beta error, where null hypothesis is accepted when it is false. So basically, the researcher thinks that there is a difference between the two groups. There is no difference between the two. There is a difference between the two groups, but in reality, the researcher feels that there is no difference, but in reality there is a difference that is existing between the two groups. So this is false negative. So the power of study is nothing but the inverse of type 2 error, that is 1 minus beta error. Suppose if you are considering beta error of 20%, if you assume, that means the power of the study you are assuming is 80%. So this is just an example for type 1 error. A doctor telling a male patient that you are pregnant. So here this is false positive. Type 2 is where a pregnant woman is being full-term pregnant woman is being told that she is not pregnant. So this is false negative. For all practical purposes, we assume error rate of alpha error to be lower than beta rate. So then generally we keep alpha error at 0.5 and beta error at this one alpha error at 0.05 or 5%, whereas beta error you keep at 0.2 or 20%. This is because the impact of false positive error, that is type 1, is more detrimental than that of type 2 error, as I explained in the previous slides. So once you are done with all the prerequisites, you have so many things. One, so what all you have? As I told, one, you have the first you decide what is your primary outcome measure, and then once you decide upon your primary outcome measure, you describe one primary outcome measure and you quantify them in the form of mean and standard deviation, and then you assume one effect size, that is the minimum difference between the two groups, and then one variance, and then you assume alpha error and beta error, and then you keep all these assumptions, and then you move on to the so we started off with all these prerequisites, and we use these formulae, various formulae. However, we are not going to calculate sample size. We are going to take the statistician self, but you should know what all you have to give to the statistician before you calculate a sample size. And these are the prerequisites what you have to give to the statistician. You have to give the effect size. You are assuming. You have to tell him what is the alpha error and beta error you are assuming, and what is the variance you are assuming. And also you should tell what kind of study design you are using, and whether it is a alternate hypothesis or null hypothesis. Alternatively, we can use many of these formula, various softwares, online softwares also, which are easy, which are freely available for calculation of sample size. For the sake of just one thing, I'll just calculate the sample size for you. So this is a study of effect of dexamethasone as adjuvant to bupivacaine in supraclavicular block. Study of effect of dexamethasone as an adjuvant to bupivacaine in supraclavicular block. So my primary objective is duration of analgesia. Okay. So this is my primary objective. I quantify that in the form of mean and standard deviation. So from the previous data, I observed that with the dexamethasone addition, it was 345 plus or minus 45 minutes. 345 plus or minus 45 minutes. And without dexamethasone, with bupivacaine, it was 265 plus or minus 30 minutes. So the mean is 265 and standard deviation is 30 minutes. Here, now, what is the effect size I am going to assume. So effect size for that is here we need to understand practically. See, we cannot take this 345 here because this is only one study which has told that with dexamethasone the duration of analysis is this much. We don't know, is it really that much? Is it, if you do repeatedly the same study, you never know whether the same value you get a value which is closer to that or not. So therefore, you just go to the control group, and the duration of analysis as per control group is 265 minutes. So to say that dexamethasone is more effective than drug bupivacaine alone, you have to have a certain difference between the two groups, and that minimum difference or the minimum effect size what you assume is 30 minutes. Okay, because that is the minimum effect size what we are going to assume to say that group A will be better than group B. So if I consider with the bupivacaine this value 265 plus or minus 30 minutes, I assume that with dexamethasone it's going to be 295, that is 265 plus 30. So therefore, so the minimum effect size what I am going to consider is 30 minutes. So therefore, by addition of dexamethasone, I assume that duration of analgesia instead of being 265 is going to increase to 295. Okay, so these two values we have to keep in mind. And then the variance as per the previous study, the standard deviation with addition of dexamethasone was 45 minutes. So I take the same variance as 45 minutes here. And then I assume the power to be 0.8 and alpha error at 0.05. With these values, I just calculate the sample size online for you. I use the software openepi.com. You just need to open this. So in this, if I go, I hope the screen is visible. So I go to this sample size here and click on that. Now we are using the mean values for calculation of sample size. So I click on the mean difference part. So I here go to enter new data. So this confidence interval is nothing but the opposite of alpha error. If I keep a confidence interval of 95, that means I am considering an alpha error of 5%, or and I keep power at 80%, and the ratio of sample size between two groups to be 1. That means there should be equal number of patients in group A and group B. Now, as per the previous this one, if I open here, I'll just in this you notice, see, you notice the duration of analysis in group A is 265, group B is 295, and the variance is 45 minutes. Okay, I just enter the same thing here in this. So group A 265 minutes, and in the as per the previous study, the standard deviation was 30 minutes. And here my anticipated duration of analgesia with dexamethasone is going to be 295 minutes, and I enter the variance from the previous study, that is 45 minutes. I give calculate. See, you got the sample size of 26 in each group. This is as simple as this. See, if you notice, all this is so simple is because I knew what exactly I have to enter in the data. Now I need to show certain things. Now, if I increase the power to 90% instead of 80%, keeping the value as the same, see, automatically the sample size increases from 26 to 35, isn't it? So that means if you want a greater power or more, if you want to reduce the error, the sample size increases. Likewise, if I increase the confidence interval from 95 to 99, that means alpha error of 0.01, the sample size increase further to 49 patients in each group. So that means the greater precision, greater is the sample size, greater is the if you want greater precision in your results, you require higher sample size. Likewise, if I increase I keep this as 95% and power at 80%, and I increase the power this one effect size from 30 to 60 minutes. So therefore 260 plus 60, it becomes 320. So what happens? See, the sample size drastically reduced from 26 to 8. That means as you increase the effect size, your sample size will come down. As you decrease the effect size, your sample size will go on. So it's important to that you always have the minimum clinically significant sample size. If you over keep the, if you keep a wider sample size or a bigger sample size, and in your final study, if you don't get that much value, then your entire data collection will be bad. So, what I mean to say is, you consider the 60 minutes difference between the two groups in the initially, and you complete the study, and at the end of the study, you don't find the difference of 60 minutes between the two groups. Instead, you find 45 minutes. Then that means the entire study becomes underpowered. So therefore, that is why it's always better to keep the effect size as minimum as possible. So once this is done, we shall move to the last part of the sample size calculation, and that's the last part of today's talk. So we calculated the sample size, and likewise we just, for various things we can do that. Once you calculate the samples, that it doesn't end there. Many times what happens is, once you start recruiting the patient can go out of the study due to various reasons. It might be patient's wishes, or sometimes the protocol might not be followed, or there might be violation of protocol, or the patient might not receive the block due to various reasons. So in order to compensate for that, you should always add 10 to 15% of the calculated sample size to get the final sample size. That means, suppose if your calculated sample size is 25, 10% of 25 is 2.5. So your total final sample size should be 25 plus 2.5, that is 27.5 or 28 in each group. So that you can compensate for all these dropouts. So once this is done, that's how you come to the final sample size estimation. Now, once you've done the final sample size estimation, everything, then finally when you start writing it in the paper, say, just mention, somebody mentions like a sample of 24 patients in each group would be required to keeping a power at 80% and confidence interval is 95%. We included 35 patients. Does it convey the meaning, complete meaning? No, isn't it? Because it doesn't convey a lot of things. So if it is written like this, the same thing, see, assuming a duration of analgesia of 150 minutes and standard deviation of 15 minutes, keeping a power at 80% and confidence interval at 95%, that is alpha error at 0.05, a minimum of 20 patients would be required to detect a minimum of 20% or 30% difference between the two groups. So if you see here, I mentioned the primary outcome measure, and here I assumed what is the baseline variance as well as the baseline value what I've considered, and what is the minimum effect size what I'm considering between the two groups. Okay. So I've mentioned the alpha error, beta error. First is the alpha error, beta error, alpha error. Then what is the variance and what is the primary outcome measure, and what and also quantified the primary outcome measure in the form of 150 minutes. Okay, and I've mentioned all these things, and I also mentioned the effect size, and this is the minimum sample size, and I included 27 patients in each group to compensate for the possible dropouts. So 24% plus 3, that is the 10% of this calculated sample size will result in 27 patients. This is the final sample size. So I've included 27 patients in each group to compensate for the possible sample, and the sample size estimation was done using www.openip.com software. If you write this way, the editor will clearly understand that you have done things in a proper scientific way, and that's how the chances of acceptance of your paper is better. Okay, then so that's about the sample size and things today. So this fairly completes the basic things regarding the research methodology. So now, so today what we learned was how to search a literature, various types of studies, and how to search a literature, and how to generate research question, and what all it should contain. It should contain PICOT, and it should satisfy PINER. And then once a study methodology is drawn, what all things it should contain the study methodology, and how to keep things standardized. and how to eliminate bias and confounding variables to ensure proper data collection, and then how to calculate what are the important prerequisites to keep in mind when you're calculating the sample size. So I think that ends the research methodology part 1. Then we will be left out with only the statistical analysis and how to write a research, how to write a synopsis. So
Thank you very much, Dr. Sudheesh. Now
yes,
it is
sir.
up to the students to give enough feedbacks as to what was their experience in the past 2 hours. From my side, I wish to really thank Dr. Sudheesh for making such a important topic so easy, fluid, and everyone can understand, and everyone will get initiated to do their thesis research work, which is academic research work. This is a baby step in their academic and scientific pursuit for their entire career. So I wish the PGs to come forward and give their feedback. All their mics can be unmuted. Anyone wants to say some, give some valuable feedbacks or ask some doubts? Okay, so I'll once again thank Dr. Sudheesh for spending his valuable time in enlightening us with all his extraordinary experience in conducting research and publications, as well as teaching research methodology and statistics in the subsequent class day after tomorrow. And on behalf of RESA and all our students, I once again thank Dr. Sudheesh for sharing his valuable knowledge and skills for us to move forward in our academic and scientific pursuit. Thank you, sir.
Thank you.
And
I know it
with your
is a
permission,
boring
I will.
topic. It's a very boring topic, but somehow I tried to make it more interesting. But we do conduct research methodology workshops, so when you get a chance, definitely please be a part of it. You will have much more better understanding of things, because that is spread over a period of some 4 to 7 hours. So it's a 7 hours program. So I have compressed that 4 hours program into 2 hours. So I had to speed up at some places, but I'm always available for any doubts. If you have, I can always clear them anytime.
That's really fantastic, sir. Actually, it's a very remarkable achievement. And now I'm seeing feedbacks in our chat box. Dr. Kritibas has commented, excellent class, sir. Can you please share the slides?
Sure, sir. Okay.
And with your permission, can I upload this session in YouTube channel, sir?
Yes, sir. No problem.
So I think that will serve the purpose of sharing the slides.
Yes, sir.
Yes, sir. So if no more questions, can we sign off this meeting today, sir?
Yes, sir. Thank you, sir.
Okay. Thank you. And I wish all the best for all of our students in their beginning of their thesis work. Most of the primary students will be presenting their synopsis for thesis. I hope today's sir's class will be very useful in making their basic doubts and uncertainties totally removed. And if we have still further have any queries or doubts, we are always available. You can put forward your queries in our Raisa channel, YouTube channel, or you can connect with us through WhatsApp or phone calls also. Thank you, sir. Thank you, Sudheesh sir. Thank you once again. Thank you all dear students for being with us and patient listening. Thank you, sir. Good night, sir.
Thank you, sir. Good night, sir.